So welcome everyone to the this breakout session 2, which is about practice. And I'm absolutely delighted to be here this afternoon to welcome you here. My name is Jocelyn Bennett, and as you can see from, I am the director of the Compassion program here at AMS Healthcare. And for those of you who are wondering what that is, it's like the best job ever. As a nurse, I get to think about how we create a more compassionate healthcare system. And as you heard Gail remark, over the last couple of years, we've been really focused on thinking about how technology can enable this and how nurses can really lead in this area. So really delighted to be here. Tanya, if you just want to advance, I would just remind everyone on the optimal viewing and recording. Oh, I think maybe there it is. So just to remind everyone to please there down in the bottom left-hand corner to mute and turn your video off so that we can have sort of an uninterrupted session here. And then on the next slide gives me pleasure to introduce the speaker for today. Now, I'm going to encourage you, in case I forget after I introduce Jillian, is to please, as the session is going along, please put your comments and your questions in the chat. I've had the opportunity to see Jillian's slides, and so I have questions about her content, but I hope that all of you will really try and engage in this in terms of putting, as I say, either questions or comments in the chat. So it's my pleasure today to introduce to you Dr. Jillian Strudwick. Jillian is a scientist at the Center for Addiction and Mental Health here in Toronto, and she is also an assistant professor at the Institution of Health Policy, Management and Evaluation at the University of Toronto. She is the president of the Ontario Nursing Informatics Group, and we're also delighted that she is an AMS Phoenix Fellow. I'd like you to join me in welcoming Jillian to the microphone per se. And also, please remember, put your questions and comments in the chat box during the presentation so we can engage in a rich, robust dialogue afterwards. And if you're on social media, please remember to use our hashtag #NursingAndAI. You'll see it down there in the bottom right-hand corner. So thank you very much, and over to you, Jillian.
So good morning and good afternoon, and thank you to the RNAO and the AMS Healthcare for inviting me today. I will be presenting on compassionate care, artificial intelligence, and nursing practice, the impacts we cannot ignore. First, I'd like to start with a disclosure slide. I don't have any conflicts of interest or anything to disclose related to this presentation. However, I did want to acknowledge that I am an AMS Phoenix Fellow through AMS Healthcare. So previous to the recorded part of this session, I asked a question about when you hear about the use of AI in nursing practice, what do you think about? And so I'm hopeful that you'll reflect during the next 15 to 20 minutes on the words that you used and think about some potentially new words or new phrases, something new that comes to mind as you think about AI specifically related to nursing practice. And then I'll ask you a similar question at the end. So the objectives of the presentation are, one, to review the use of the terminology AI in the context of healthcare and, of course, in the context of this presentation. The second is to identify current and future applications of AI or AI approaches within nursing practice specifically. The third is to discuss the impact of the application of AI or AI approaches on nursing practice. And then the final objective is to describe how compassionate nursing care can be situated within a context in which AI or AI approaches within nursing have become commonplace. So I want to begin first with a story, and a rather personal story. So this is a map of Southern Ontario, and we'll start right in the middle of the map in Peterborough, Ontario, which is not far from where I grew up. My father worked in the factory here that you can see the photo on the screen for a number of years, and this is where I had a job where I was of university age, and I was placed with the occupational health nurse. I had the wonderful experience of exploring the factory during that summer and seeing the use of robotics, automation, and data that was used for decision making. So fast forward to my nursing degree at Kingston General Hospital, and when I'd entered my first medical surgical placement and didn't see any technology, I was concerned about a couple of things. One is potentially missed care, so not necessarily alerts and reminders and that sort of thing, which of course as a nursing student you're always very concerned about. But the second thing is we had amassed a lot of data, particularly nursing assessments, nursing documentation, multiply that by the various other health professionals within the health records of patients. And we weren't doing anything at that time to necessarily aggregate them in meaningful ways. And so what I was thinking about at that time, and I didn't know the language, was the field of informatics, but also the AI space and some of the methods that I would be thinking about in the future, like machine learning. So now fast forward to the left-hand side of the screen, which is where I'm at now in Toronto at the Center for Addiction and Mental Health. And we're starting to see some of the application of AI within our organization, but it's still in its very early days. And so we've got a long way to go. And I think nursing, particularly those in practicing roles, have a lot to say with regards to where we need to go with AI. So what is AI in the context of this presentation and for the symposium today? So the definition I'll use is the theory and development of computer systems able to perform tasks normally requiring human intelligence, such as visual perception, speech recognition, decision-making, and translation between languages. So let's put it in very practical terms. So if we think of AI as replicating human senses and skills, so seeing, listening, and speaking, one of the AI technologies could be, say, speech recognition technology. If we think about AI in terms of learning, reading, and writing, an example could be natural language processing. And of course, as we think about AI as movement, I think what comes to probably all of our minds is the use of robots or robotics. So let's go through a couple of examples of applications of AI within either healthcare in general or within nursing practice already that are probably more in smaller areas or more limited. It's been rolled out more limitedly right now, but we might see in our practice more commonly in the future. And so the first is seeing, listening, and speaking. And on the left-hand side, you can see how AI can be utilized to analyze images for clinical findings. And so there's been some research that shows that AI can be as effective or even potentially more effective at determining clinical findings as clinicians. Still not widespread, but we might see this more in the future. And then on the right-hand side, AI chatbots. So particularly in the clinical environment that I work in, which is mental health, there are a number of AI chatbots that use approaches related to cognitive behavioral therapy. So let's think about AI as it relates to human senses and skills of learning, reading, and writing. So on the left-hand side, we're used to, as nurses, doing probably a fairly large amount of documentation in the work that we do. And there has been work, a lot of it directed at our physician colleagues, but more so now within nursing, looking at voice recognition technology, as well as voice text documentation. So traditionally, we've used back-end dictation, so dictation done by, say, a health records department, and now there's front-end dictation, where you can actually speak into a device and do it in real time. On the right-hand side, we're also thinking about how we can actually use a lot of the data within the EHR to predict things like falls risk or suicide risk. And that would use nursing documentation. And there are cases in Canada where we're starting to see this. My organization has been looking at using nursing documentation for suicide risk prediction. And in areas of New York, Florida, Boston have been looking at falls risk with AI algorithms. And of course, movement. So on the left-hand side, you can see there's a tablet device with a nurse, and that nurse can control where he or she wants to go in a clinical context. And in an area that I worked in an ICU several years ago, I worked with a robot that was controlled by a clinician on the other side of the world who would then go around the ICU and do rounding at that time. So not necessarily a new technology by any means, but the application of how we're using it is still not commonplace, but we can think of probably a lot of ways that we could bring in expertise when and where we need it. And then on the right-hand side, robot-assisted surgery. So this is primarily focused at our physician colleagues. However, as we think of some very unique skill sets like wound care, there may be an opportunity for there to be robots assisting with some of those kinds of care. So let's look at the non-healthcare context. What are some of the things that are going on outside of healthcare, which tends to be a bit further ahead when it comes to AI than our space? And so within the seeing, listening, and speaking domain, there's a really interesting technology that uses cameras and sensors to monitor drivers' levels of drowsiness. And I was speaking to someone who had just gotten back from a high-risk environment, a mining environment, who said that they were using this technology, and when they identified that someone was drowsy, they actually had the seat shake of that individual to kind of wake them up. And so if we think about the clinical context in which we practice as nurses, particularly in hospital settings where we've got the night shift, where we've got weekends and evenings that you're working, and so long shifts, these are times when fatigue sets in, and we may be more at risk of making a mistake. And so should we have a technology like this in place? What are sort of the ethical implications of that? Do we want something like this to be in place? So lots of things to think about as we translate some of these technologies from the non-healthcare world into our nursing world. Another potential application from the area of movement is drones. And so in other countries, there have been some approvals that signify that we're getting to a place where it may not be too long before we have packages delivered via drones. And so I think we can probably think of some examples of where drones potentially could be used for healthcare or providing access to, say, vaccines to certain communities where potentially they're not able to land due to weather or other functions. And I think we can think of many examples of that. So lots of potential for AI. We started a little bit with AI within nursing, but lots of things to consider. So the first is that many of the things that AI can do are potentially tasks or decision supports. And so from the task perspective, if some of the tasks that are less meaningful for a nurse to do, or that an AI device or technology can do better than us, would there be a potential for more time for nurses to do other things? And then what would we do with that time? Right now, time we often don't have. So would it be that we would be doing the current work that we're doing in a different way? Would we be doing more of it? What does that look like? And that leads to the second point, which is a shift in the nursing role. So if AI is replacing some of the things we're doing, or doing certain things better than we can do, for example, analyzing lots of data for decision making, what will our role actually look like? And what will our role be in interacting with the technology? And that leads to the next point, which is we've seen a huge increase in the use of remote care as a result of the pandemic. With virtual assistants or robotics that can support actually the doing of tasks, coupled with data analysis, virtual care and monitoring, we may be able to offer more and more care remotely. But this doesn't come without its limitations. So some of the limitations and some of the things that we need to think critically about are about AI and biases, particularly as it comes to thinking about some of the algorithms that we're using for decision making that may come from the data that underlies those algorithms. So some of that data may reflect historical or social inequities, like a lack of a diverse sample or a measurement error in how that information was collected. The second is AI and ethics. And so there's a potential to create a number of ethical challenges related to things like patient preference. What if a patient doesn't want their data to be part of something that's used for complex decision making? Or what if they don't want to have virtual care? They want to see someone face to face. And patient safety, often AI is touted as being able to support and improve patient safety. But what if there's something that was a patient safety issue as a result of the AI technology? And then same with patient privacy. How are we thinking about consent? Many of these devices are owned and operated by private organizations. Where does that data go? So lots of things to consider as we think about AI within nursing practice. Other considerations. So one thing is the penetration of AI into our nursing world may be slower than we anticipated, but we can anticipate that it will have larger impacts. The second is clinical processes for employing AI-based work are a long way from being ready for daily use. So our organizations that we work at now aren't necessarily ready, don't necessarily have the structures in place, perhaps aren't nimble enough at this time to be able to accommodate some of the technologies that we've talked about. And that's likely because they've been set up for the current context, which is the current technologies and processes that are in place. And then third, certain AI applications, and I showed you one earlier of image recognition for scans, require large volumes of data. And right now, the way we've structured our data within most organizations in Canada is they sit within an individual organization or a health region, and they aren't necessarily shareable between organizations. And so some of these applications require that you have to bring large volumes together. So we'll have to think through about what that looks like, how we do that effectively. And of course, there's lots of considerations like privacy to consider in doing so. So some key questions for you as you go through the rest of today at the symposium. So one of the questions is, who is making the decisions about what and how AI is implemented in the nursing context? Do we have enough nurses in powerful or influential positions to influence this? And then third, do we have nurses who truly understand this, the implications of AI for practice, education, leadership, and beyond? So I'm going to shift gears a little bit and talk about the last objective for today, and that is this idea of digital compassion. And so we know digital health is the use of IT and electronic communications within healthcare delivery. And we're probably, as nurses, fairly comfortable with the term compassion, which is, in this case, we're talking about an empathetic response, but that difference between empathy and compassion being that there's an action that comes with compassion. So I'm going to provide an example in my own practice of where I've enacted or tried to enact the digital compassion. And so this story goes back a couple of years to when I was working on an inpatient mental health unit, and I was caring for a gentleman who was going to be discharged in a few weeks, and he was looking for a new apartment to move into. So he's looking on different websites, finding photos of apartments, and he shared with me how frustrating it was that because he didn't have passes to go into the community, he could see the pictures of the apartment, but he really couldn't get a sense of where the apartment was, what resources or was there a bus stop in the area, what neighborhood was like, etc. And so, fortunately, we were able to sit down with a laptop and we pulled out Google Street View, and we're able to go on virtual walks around the neighborhoods of the various apartments that he was looking at. We looked for things that, of course, would be necessary upon having a successful discharge, like having a bus stop present, a pharmacy or a grocery store, these sorts of things. But in general, he wanted to get a sense of what the neighborhood looked like, and if it was something he would feel, somewhere he would feel comfortable moving to. And I thought, wow, wouldn't this be amazing if we had a virtual reality headset or something like that, in which we could physically go for walks with our patients and prepare them for discharge in this way. So in order to be able to do these sorts of things as nurses, we need to be able to have technologies that have various standards and attributes that support digital compassion. We should have competencies as clinical professionals to be able to enact digital compassion. And then, of course, our organizations have to situate us in the appropriate context, have the appropriate processes in place to be able to enact digital compassion. And so right now, I'm working with some colleagues at the University Health Network and with AMS Healthcare to think through this. What all is needed to be able to provide digital compassion as commonplace. So in conclusion, so AI has the potential to shift clinical care and nursing practice. And I think some of the examples that I provided here today speak just to that. However, we've really just begun our journey in the AI space. And so we've got a long way to go. But we're in a place where we need to think really critically about how we want to use AI and what impact that has on our role as nurses. And then finally, we need to think about, understand, and apply this idea of digital compassion. So we can have fancy technologies, sophisticated technologies that support the care that we offer to our patients, but we need to ensure that we also still provide it in a compassionate environment. So I thank you very much for today, and I will be asking you a question in a moment related to your thoughts about phrases, words that come to mind when you think about AI and nursing practice. Thank you.
Thank you very much, Jillian. That was wonderful, and I really appreciate your thoughtful comments on this. And for those of you that have not, I had the privilege of actually hearing the presentation yesterday. And so as I listen to it, I really start to percolate on other ideas. So I would encourage you all of the sessions will be recorded, including the ones that you're not in right now, but to listen to them again, because I think there's some pearls and interesting ideas there. Now, I think, Jillian, you're asking your question again to people about putting your thoughts in the chat box in terms of what new words or phrases come to mind. And I would also encourage all of you to add questions to the chat, because I think we're really wanting to use the next 20 minutes or so as an opportunity to have dialogue. So I am going to go after one of the comments that I go after, that doesn't sound very collegial, but I wanted to raise one of the questions that you spoke about, because it also came up in the chat, and this is this idea of time. And we heard Tracy speak in the opening plenary about Eric Topol and the gift of time, and one of our participants today is raising the question about technology always seems to promise more time, but that's not been the lived experience of people on the other end. And so I'm wondering if you could speak a little bit about what does the data tell us about this? How is it that time gets leveraged? Are we talking about creating time in this particular place, or is it that it's part of the whole care system? So I'd like your thoughts on that, Jillian.
Sure. So there's a few things that come to mind when I think about time. So let's pretend that we are fairly confident that some of these technologies are going to provide us with extra time. And so if that's the case, I think back to my time as a medical surgical nurse and think about how frantically we were running around providing care and what extra time would mean. And so if that means slowing down a little bit and being able to provide care at a level where I could take a deep breath and do so at a pace that was what I would feel is more appropriate, I think that in one sense would be a huge bonus. There's a whole bunch of literature related to care left undone. And so I think there's an opportunity there, if we were to have extra time, that we would be able to get to that, and there wouldn't be this whole literature base of care left undone. And then I think of a downstream effect of extra time as well as improved wellness for nurses in themselves. So it's really stressful, some of the environments that we're in. And some of it has to do with the number of things that we are required to do in a pretty short amount of time. Often, if you're working in an environment that has, say, a shift, a 12-hour shift or whatever that might be, how can you do everything and do it at a level of quality that you feel good about when you leave at the end of the day? And so that's that, if there is time. What about the data? I think was one of the questions that you asked, Jocelyn. Well, it depends. AI is a huge concept. There's many different technologies out there that utilize AI. Some of them don't promise time savings because of the nature of what they are. They might promise the fact that they can support decision making. Maybe that is a time saver if nurses would typically have to go through a health record and sift through numerous pages. It's a bit of a tricky question to answer with regards to what's the data show because of how varied the field is. But I do hear what the individual who wrote about, sometimes things are promised as time savings and it doesn't end up being that way. Sometimes that's because we haven't optimized the process. We've implemented them and then kind of left them, rather than having nurses continuous feedback, having some sort of process at their organization to come back and make that process or the use of the technology better. So I'll stop there. But I think it's an initial set of thoughts for this. So a bit
of a follow-up, and I can't remember who. Anyways, I'm not going to attribute the comments to people because I've been sort of cutting and pasting quickly on here. But one of the questions came back is, but does more time actually mean more compassionate care? Or is it just an option that some nurses with more time can access? And maybe if you could think about that and reflect on, like I was thinking about the, this slide, used by AVAs people. Those of you that know me know I like AVAs. But this one here that talks about digital compassion, thinking about standards, competencies, and processes, context processes. So how do we make that happen so that, because more time doesn't necessarily mean more compassion?
Right. Compassion, being able to provide compassionate care, there's so many different influences to that. As you mentioned, Jocelyn, so that slide in particular talks about sort of three main buckets that influence nurses' ability to provide compassionate care. So one being, if we're providing it with technology, for example, with or through technology, does that technology, does it have the technical abilities? Are there specific standards in place that support the delivery of compassionate care? The second piece being, have we learned how to do that? So the example I provided with using Google Street View, we were just kind of lucky that we fell on that. But there are lots of ways that we can leverage certain technologies in a compassionate way. But we need to know about them, think through how we might work with them. How do you actually physically hold a technology or have a screen present in an interaction if that's the case? So that's the whole level of competencies of health professionals, is that skill and knowledge and understanding how to situate it. And then the third piece then being, okay, so you've got the technology and you know how to use it, but do you have the environment, the processes to be able to do so? And so all of those things have probably more questions than answers at this point in time. And this group on this webinar, our session right now, is probably the key group that can think through that.
Mm-hmm. Okay, thank you very much for that. There's an interesting dialogue going on here. I will name, because I've actually figured out that I should cut and paste the names with the comments, between Tim Guest, who's the president of the CNA, you're going to hear Tim later, and Rob Fraser. And one of the comments that Tim is making is around, the importance of nurses being involved in the development, implementation, and evaluation of projects and processes. And Rob's coming on with agreement on that. So given that we know we need to have, or we should have, and I'm biased, I'm a nurse, I think we should have nurses engaged in this. Can you talk a little bit about maybe what you've seen, what some of the best practices are, and what do we need to do as nurses to really get in here?
So I love this topic, first of all, and it's, I don't have the chat coming up in front of me, not to distract myself from this conversation, but I'm so glad that this has been brought forward. So in thinking through how nurses can influence and be a part of the whole process. So coming up with the idea to perhaps, well, not perhaps, being part for sure of the design or co-design. And that flows through to any sort of implementation and planning, then to the actual use, then of course to evaluation, and then having a feedback loop so that, okay, once you've used it and you've evaluated it, you're constantly making some changes to that so it works for patients and nurses. So to talk about the roles, I think there's some really interesting folks in these roles in Canada. So I think Rob's probably in a role, Rob Fraser's in a role where he's influencing and leading as a nurse a particular technology in all sort of stages. And so that's a little bit uncomfortable for us as nurses often to get involved in some non-traditional nursing roles. And so to have sometimes the most influence, we have to go outside of our comfort zone and delve into some of these sort of non-specific nursing roles, but bring our nursing lens to them. The other thing I would say has been really helpful for myself is having nurses that are influencing at various levels. So nurses influencing at a leadership level, at that decision-making level. So they've got financial and human resource responsibility that provides you some degree of power and influence. To if you're a direct care nurse, you know what's going to work. And so influencing at that level as well. And then there's some really interesting roles. So there's the idea of having nurses who practice, say, in hybrid roles, where maybe they practice a couple of days a week clinically in their clinical role, but perhaps they are in a project manager role for a couple of days a week, or they're in on an interdisciplinary team where they're influencing a project implementation or a study or whatever it might be in this space. And so those roles aren't as common as I think they could be. Our physician colleagues are amazing at this, having clinician scientist kind of roles. It doesn't have to be the scientist role, but the whole idea of having a hybrid role where you're grounded in practice still. So I'll stop there because I could talk about this for a really long time.
I can see you're passionate about it, which is great. One of the areas, you're getting thanks in the box, the chat, by the way. One of the areas that surfaced early on, and I wanted to get back to a little bit because I think it ties into a lot of what we think about as nurses when we think about risk assessment and critical thinking, and how is it that we, as nurses, and there's been some questions about what about when technology fails and how do you manage that? So could you speak a little bit about this? I mean, you talked about some of the risk screening that's done with, falls and with suicide identification, and how do we start to, how do we work with that? And what's the, how does that input into us as nurses in terms of our critical thinking? And, what about if the AI says one thing and I think something else? So big field there for you to chat.
Yeah. So what immediately comes to mind is we do risk assessment screening now. And so one of the things that as a result of risk assessment screening is often the development of a care plan, maybe an order set that's triggered if we do our risk assessment within some sort of a health record system. And so some of it would remain fairly similar to what we're doing today. We would still enact some of these same processes. In other ways, though, it's quite different. So what if we don't agree? And there's some interesting work done in the imaging space where AI essentially says we found clinical anomalies in some images, but 10 clinicians look at those same images and say we don't see anything. So what do you do there? Are the 10 expert clinicians correct? Or do you sort of believe, I know I'm using AI as this vague, big term, or do you believe that AI? And so that's a whole area that is something that we need to think through as nurses. I don't think I can provide any sort of solution, but more say that in any one of these scenarios to have some good supports and discussion, or so good discussions so that we can identify what the support is for nurses in facing these scenarios.
Yeah, thank you. It's interesting. Patty Smack, I'm not sure who Patty is, but she comments about wound care. How can a robot smell and touch and see what's going on in the bed? I suspect the AI can see. I'm not sure exactly how that process is in there, but it's really thinking about what is it, how is it that the AI can augment. Just looking to see if there's any last questions here. I think, we've got a couple of more minutes. Rita's, this is an interesting comment. Rita has put in here for at 2:40 for everybody to flip back to the main room for the next concurrent session, or not concurrent, but panel sessions. But there's an interesting question here about somebody being fascinated with the idea of nursing intuition and how it can be connected with AI. And I'm going to date myself, but I grew up in the age of Pat Benner and her novice to experts. And we used to always think about, as people moved on that trajectory and became expert nurses, it wasn't that it was so much intuitive, it was the ability to synthesize data and knowledge in a different way that got reflected in your practice. Any thoughts on how, what are the implications for nurses as we think about this idea of the development of expertise? And are we going to, are we going to become dependent upon the AI and therefore not develop that? Or is it actually going to augment?
Yeah, it's a very interesting question. I have a PhD student that I'm working with right now who's very interested in basically comparing clinician decision making and the process of decision making, and comparing that to a very structured approach to essentially how AI, I'm going to use the big vague term again, does that decision making as well. Knowing that there's some pieces that are really hard to describe and label when you're making decisions, particularly about risk, for example. And in my environment, I work in mental health. Suicide risk is one of them, risk of aggression, these sorts of things. So we know there's a number of predictors that are pretty well, they're in the literature, we've known for a while. And yes, we can base our decisions on that, but sometimes there's this other piece that we have a hard time kind of describing. And so that part, how do we bake them into these algorithms? Maybe we never can. And so I see it as the AI decision supports as assisting with decision making, not necessarily replacing decision making. And so that there's that intersection when you've got whatever the output of the AI risk assessment or whatever it is, with your intuition. And that's kind of where you can make a clinician decision. But then we also have to think about, we haven't even talked about patient preference here, or family members, or the contacts. So there's other pieces that come into the decision-making process as well.
Okay. Well, thank you very much for that. Now, I believe we are at time, and because it was supposed to be at 2:38, I'm directing you back to the main room, and it's 2:37. So Jillian, I'd like to thank you so much for your presentation today, and particularly your thoughtful comments and reflections on questions that came from all of the group. I would like to actually thank, lots of kudos to you in the chat. I would like to thank everyone who joined today and who has taken the time to put their thoughts and ideas here. This work is critically important to what we see as our work at AMS Healthcare, and I know also the RNAO. So I would encourage you to stay tuned into this as we carry on our conversation, and invite you all to go back to the main room for the next exciting panel. It's going to be talking about what's the leadership we need to move this forward. So thank you very much.